Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Tonight we have a very interesting show, something very different. We're going to be talking about head and neck surgery. And for that, I have a wonderful expert in that field, Dr. Sam Trosman, who is at Richmond University Medical Center. And we'll talk about training, and we'll talk about head and neck surgeries. And on Staten Island, sad to say, so many of our patients, so much of our community smoke a lot. There's been association with alcohol use. And head and neck surgeries sometimes don't get recognized early enough. And I think it's a major public health issue that we recognize it and discuss it with our audience. The idea if you've got a lump, a bump, something that you don't think is right on your tongue, your throat, that you seek attention. And we'll talk about how you get to a head and neck surgeon if you do need the surgery. And whether the surgery out here on Staten Island or in the outer boroughs really is as up to par as you're considering going into Manhattan. So we're going to talk about a lot of different topics with this, but really to get us started with this, with Dr. Trosman, tell me a little bit about what a head and neck surgeon is. I know you're also an ear, nose, and throat specialist. Mm-hmm. That's a lot of different words, head and neck, ear, nose, and throat. There's a lot of parts of the body in it. So tell us a little bit about your training and how someone becomes a head and neck specialist.
Yeah, absolutely. So thank you for having me.
Thank you.
Generally, head and neck surgeons sort of implies that you're dealing with tumors of the head and neck area, both benign, meaning non-cancer growths, as well as cancer, which basically are tumors that have a propensity to spread. Generally, you got into head and neck surgery from after doing an ENT residency first, although there are general surgeons that go into it as well as oral maxillofacial surgeons. And then the majority of head and neck surgeons that graduate today do a fellowship at an academic center, specifically in head and neck cancer care. Mm-hmm. That was my training. I did my residency at Cleveland Clinic, and then I did a fellowship in head and neck oncology and microvascular reconstruction, which the majority of head and neck fellowships these days encompass both, down at the University of Miami.
Oh, wonderful. So tell me, how do patients get to you? Again, I know you have an office out here, mm-hmm. and who refers patients to a head and neck specialist?
Yeah, it's really a variety. I would say the vast majority of referrals come from either primary care doctors in the community and ones that we have relationships with who seek patients that come in, say they notice a new bump or their voice is hoarse, or they see a spot on their tongue. A lot comes from dentists and oral surgeons who have patients that come in with sounds like tooth pain or jaw pain and end up having something in their mouth that's suspicious. And then a lot comes from other ENT otolaryngologists in the area that either are subspecialized in something different or that do general ENT. A lot of otolaryngologists that do general will do some head and neck tumors, they'll do thyroids, they'll do some parotid or salivary gland tumors, but when it gets into kind of the more complex, either revision, patients that have had surgery in the past, or that have more advanced invasive tumors or cancers, then we get some of those referrals as well.
Tell us a little bit, why do people get head and neck tumors? Is it something that is the environment? I mentioned alcohol, cigarette smoking. Tell me a little bit about why people get them and what people could do, what modifiable factors they have for these type of things.
Right. Well, when you say head and neck tumors, it's really a pretty heterogeneous, it's a diverse group of tumors, so it really varies. I would say the majority come from the mouth and the throat, what we call the aerodigestive tract, and those tumors, the main risk factors that are modifiable are both smoking and alcohol. Smoking, is far and away number 1, 2, and 3 risk factors. So the number one thing you can do is not start smoking if you haven't. If you have been smoking, then to find a way to quit. And there's a lot of good resources that we have at RMC that can help.
If you do stop smoking, does your risk go down considerably?
It does.
We talk about with lung disease and heart disease. They say 1 day of stop smoking, 1 week, 1 month, 1 year. Tell us a little bit about if you stop smoking, does it decrease your risk of tumors of the head and neck largely, or what?
Yeah, absolutely. I think the data has shown if it doesn't ever get back, once you have smoked for, 5 or 10, what they call pack years, or once you smoked a pack a day for 5 years or half pack for 10 years on up, it never gets back to zero risk as if somebody has never smoked before. But if you stop, then your risk doesn't continue to go up. It sort of plateaus off. So certainly it's never too late to quit.
And that's wonderful advice for all of us. So tell us a little bit, when I was growing up, we'd always sometimes see a patient or person who had a tumor of the throat or smoker usually, or the tongue. And we'd see these radical procedures. And when in medical school, I remember they were called a radical neck dissection. You see a large portion of their neck removed in order to take the tumor out and try to give them the best prognosis. You were telling me before we started the show really about some of the newer techniques. And I think taking some of the fear of the disfigurement out of this, it would be something very helpful, because I've had patients who years ago used to say, I don't want that procedure, no, even if I don't survive. And it sounds very heinous to say that, or it's very difficult to understand that. But I think after seeing a number of patients who've had major surgeries of the head and neck, and we've seen many of these people who many years ago actually did well with that type of procedure, and really come out very disfigured with the musculature all dissected or taken out. So tell us a little bit about what happens now, because again, things have changed so much in surgery with less invasive procedures. Tell me a little bit in the head and neck field.
Yeah, absolutely. So the example you gave is a great one with the neck dissections, which is essentially removing the lymph nodes that are involved with cancer or fear to be involved with cancer in the neck. And years ago, they used to do, like you said, radical neck dissections, which implies removal of muscles, potentially of skin, of some of the nerves that supply kind of key structures in the head and neck area. And over time, we've shown that it's safe to do those procedures while sparing a lot of those structures, and it really minimizes the morbidity. So things like the nerve to the shoulder, the nerve to the tongue, those are now able to be spared. We've shown that we can do that and just remove the lymph nodes themselves and go between critical structures. And things like the wound care, like the appearance of the neck, like shoulder function and swelling after removing some of those lymph nodes, that's really gotten a lot better, to the point that you see somebody who's had this procedure, you may never know it.
You were telling me about reconstructive surgery. I mean, we know that with breast reconstructive surgery after cancer. Tell us a little bit about what do you do and how do you do that?
Yeah, absolutely. So, unfortunately, if you have a tumor, if you have cancer of the head and neck, it's a finicky field because there's a lot of critical structures in a small area, and especially in the throat, where you have structures that are so integral for speech, for swallowing, and for breathing. And after removal, you really want to do everything you can to get the patient back to their quality of life. Being able to speak in their normal voice and being able to eat whatever they want is huge to patients. It's a significant quality of life issue. So what we found is for not every tumor, but certainly for some of the bigger ones or some of the bigger cancers, we're able to return back to function better if we use what's called free tissue transfer, which is essentially, the way I think about it, is it's a transplant within yourself, where you're taking a portion of tissue from somewhere else in the body where you can kind of spare it with its blood vessels and hooking it up to the blood vessels in the head and neck to be used in order to recreate both your aesthetics of the head and neck as well as your function. And luckily, because it's within yourself, you don't need the usual transplant kind of downsides, things like medications that suppress the immune system, and chronic rejection, things like that aren't an issue because it's all your own body.
Tell us about the team that you have. I mean, clearly you're a wonderful surgeon, very well trained surgeon.
Thank you. That's very kind of you.
And I'm sure your family's all proud of you. And the idea is there's a team approach.
Absolutely.
There are nurses, and maybe describe all the people who are involved in someone who comes in with this type of procedure.
Yeah, absolutely. So, it's everything we do is in a multidisciplinary fashion. So I work with Dr. Lisi, who is our chief of otolaryngology and is a great general otolaryngologist at Rumsey. And he also trained at Miami, so we have some familiarity there, which is a very high volume center for head and neck, tumors and cancer. We have, as far as cancer care, we work with excellent hematologists, oncologists, and radiation oncologists that are very familiar with head and neck cancer care, because any radiation oncologist will tell you head and neck cancer is probably one of the most, if not the most difficult cancer to treat because of the structures involved. We have speech pathologists that are excellent, that are really key to a lot of our rehabilitation and a lot of our evaluation, both preoperatively and postoperatively. We have nurses. We have a full operating team of dedicated nurses and technicians that work with us. That we work with over and over again. Mercer University Medical Center as a whole, the hospital provides a ton of radiology, pathology, a lot of the support that's really necessary.
So the team is really in place to give the best quality of care.
I think so.
I learned a lot from you when we were talking before we went on the air, and it was surprising to me that I didn't realize that a head and neck surgeon would take care of skin cancers, whether it's melanoma, squamous cell, basal cell, advanced, invasive type of skin cancers. Tell us a little bit, because I think of that more of a dermatologist and another specialty. Tell us how head and neck surgeons get into that, and what are these only skin problems on the head and neck, or where do you commonly see them, and give us a little bit of an idea, especially for when you're dealing with our audience. We're trying to take a look and try to get a feel. Everyone has a dot on their scalp, or a little bump on their head. Does someone have a lipoma? All those kind of things. There's always that fear. When you see it in a young kid, you say it's probably nothing. But when someone's older and you've had some exposure to the sun, and you feel a lump or a bump on your head, how do you figure out what it is? And then tell us really what your role is with regard to skin cancers of the head and neck.
Yeah, absolutely. Look, I think the vast majority of skin cancers are still small and are at an early stage, and nationally the vast majority are treated locally in the office by dermatologists, by skin specialists. And I think that if you notice an area of discoloration in your skin, or something small that's not painful, a dermatologist is a great place to start. And I'm happy to help as well, but I think over time that'd be a great doctor to see, as far as tracking you and really having the expertise to do some of the office procedures. Where we get involved generally, and for skin cancers, we get referrals from primary doctors as well, and patients walking in, but a lot of it is from the dermatologists themselves, where they either see something that's growing or grown beyond what they can do in the office, or that they feel comfortable with. Either some sort of skin cancer that's gone too big, or one that's shown that it's more aggressive than kind of your typical run-of-the-mill variety. So I think skin cancer is the most common cancer in the world, and the incidence, the numbers are increasing at a huge rate because of the increase in sun exposure in different areas of the world and in the country. So I think the big things to look out for, everyone has little spots or moles or things like that on their body. The big things to look out for is when things change. When you've had a mole that's been there forever and suddenly it's bigger and suddenly it's growing, or if it's bleeding, or if it becomes painful. Those are definitely things that you will want to get checked out for. While you can have skin cancer anywhere, a huge proportion of those are in the head and neck, because it's a sun-exposed area. A lot on the scalp and the ear, areas that kind of historically get a lot of sun. So we tend to see it from dermatologists once it gets more advanced, but we're always happy to help out if you have anything on the head and neck that we can look at.
You're also telling me about benign lesions. So not everything is a malignancy. So you talked about the reconstruction and all the major procedures that people do, but sometimes it's nice to have someone who has a benign lesion, something you take off. Why would someone refer to you? Is that your area because of your technique and because there's so many delicate tissues there? Or tell us a little bit what kind of benign abnormalities you take care of.
Yeah, absolutely. I think it's it's probably just a combination of the familiarity with the anatomy and in the field, and with some of the procedures. So, benign lesions, the ones that come to mind, are ones of the thyroid gland, where a lot of nodules, thyroid nodules, are increasingly common, where they either have an ultrasound for some reason, or you feel something and they show some sort of abnormality in the thyroid. Well, there's no way to know for sure whether or not that's cancer, and that could be something that's life-threatening until you remove it. And we have great, great systems in place where we can extract some cells with a needle and give you a risk stratification. And that's gotten, the techniques for those have improved immensely over the years. But still, we're the only gold standard is to actually remove it and take a look. So certainly we do some surgery for benign thyroid disease. Sometimes the thyroid can grow so big that it actually causes compression and causes issues with swallowing and breathing, where it pushes your whole voice box over. So we do some of those. And then there's the lesions of things like the salivary glands, which
So where are those?
so there's 3 sets of major salivary glands, and then there's a lot of what we call minor salivary glands throughout the whole kind of throat and mouth. And the major ones are the parotid glands, which sit right in front of your ear, right here. They're the submandibular ones, which are actually aptly named because they're right under the mandible, under the jaw. And there's called the sublingual glands, which are underneath the tongue. And the parotid glands are the major ones where most of the tumors we see in those are benign, meaning are not cancer. And we remove them because some of them have the propensity to grow and cause facial disfigurement. Some of them can actually turn into cancer over years, so we recommend having it removed. Yeah, a lot of the techniques for cancer removal are the same, because some of the cancers that we see in the area or in other areas are, even though they're technically cancer, meaning they have the ability to spread, they're generally very favorable prognosis, meaning patients are able to be treated fully with them with just a small surgery. And those surgeries can be very similar to what we do for benign lesions, non-cancerous lesions, which is why I think some of the techniques overlap.
It's interesting. We talk about the salivary glands. As a neurologist, I have a lot of patients who have increased saliva production. People with Parkinson's disease, they can't swallow as well. There's a lot of saliva there. So we use Botox into the saliva glands. I don't know if you guys are doing that too.
We have, yeah.
But it's very interesting. There are ways that, for really no great reason, we don't really understand the how it works, but injecting small amounts into these parotid glands and submandibular glands will actually decrease the amount of saliva that's being produced.
Right.
And help a lot of patients. Some of the medicines we try to use sometimes for on the medical side for it don't always work. So it's interesting that we have that overlap.
Yeah, absolutely.
With the salivary glands.
Right. No, absolutely. We do that. Sometimes one of the issues we talk about with surgery of the parotid gland is essentially what they call Fry syndrome, which is sweating while you're eating. And that's where, the theory is that the nerve supplies sort of cross when the nerves regenerate after that kind of surgery. And you get, the nerves to the skin cross the parotid, and instead of creating saliva while you're eating, it actually causes some sweating from the skin follicles. So Botox is something we use for that as well.
It's interesting, because there's even another term, crocodile tears, that we use for my field, where someone's smiling and tears are coming out of their eye because the nerves become somewhat crossed over when they regrow. You were also mentioning about the throat, and in the throat, the vocal cords. A lot of our patients, you see a lot of people who have very hoarse voices, and you're an ear, nose, and throat doctor. So if someone has that, and if they go to an ear, nose, and throat doctor, what are you looking for? When people talk about their polyps, Broadway is opening up, and we hear about singers who have polyps. Are those the kind of things that you guys take out?
Yeah, we definitely can. I think we definitely get referrals or people sent to us for hoarse voice or for voice changes. From a cancer standpoint, it's always more concerning when somebody's sort of slowly declining and the voice never goes back to normal. It's a little bit more reassuring when their voice kind of gives out at the end of the day, but then they wake up and it's back to normal, because lesions of the vocal cords that are permanent, or that something that could be pre-cancer or cancerous, usually will never go back to normal. It'll always be abnormal. So now again, the majority of nodules, of lesions of the vocal cords, are not cancer. are benign, but they can have a significant quality of life as far as, like you said, people's voice is key to a lot of different professions, to a lot of different lifestyles. So that is something that we can treat. We usually do it in combination with the speech pathologist as well. A lot of those conditions, such as nodules, are amenable to voice therapy and can improve with just speech therapy. But some of them are not, and some of them are actual structural issues where you need to do a procedure where you're removing a portion of that lesion while sparing the majority of the vocal cord.
And how does it happen? Because these singers are using their vocal cords so much, or is there a reason that they get polyps in that area?
Yeah, polyps, they're essentially reactive into inflammatory tissue. It's benign, meaning it's not cancer, but it can the theory is that there's some sort of injury that's caused the vocal cord, some sort of overuse or misuse that then just perpetuates and grows. So, polyps are one that, if they get to a certain stage, if they get big enough in the vocal cord, they require some sort of procedure in combination with the voice therapy to try to alleviate whatever that kind of misuse was that caused them in the first place. And unfortunately, sometimes it requires a little bit of voice rest, meaning not that you can't talk at all anymore. That's not practical in today's world. But kind of a limited voice rest where you're kind of only speak when spoken to and really limit talking on the telephone, limit whispering, shouting, things like that.
And that really helps? It actually makes the polyps smaller?
It certainly can. The theory is you're trying to eliminate some of these kind of behaviors where you're not able to modulate your voice. And when you speak on the telephone, a lot of times you're in either crowded environments or you're in situations where you don't realize that your voice is straining or your voice is shouting. Or the other side, if you're whispering, that really can strain your voice as well.
So, and clearly, just to talk about the things that you don't do, as a neurologist, you don't do brain surgery?
No.
Okay.
There is some overlap where we work closely with, on the upper side, we work with our neurosurgeons, especially with areas of the skull base or the bottom of the brain, or sort of the bottom of the housing of the brain. And then we work with our thoracic surgeons, like Dr. Harris, as things get down to the base of the neck. But yeah, anything inside the brain, we would always involve the neurosurgeon.
Okay. Just wanting to just to know that. So no talk in 2021 would be complete without us talking about COVID. And interestingly enough, I don't know if most of our viewers know that really one of the largest population of physicians who were affected by COVID initially were ear, nose, and throat specialists. And it made sense, dentists and ear, nose, and throat specialists, because you go face to face with the patient, and especially earlier on when we didn't know about how it was spread and how commonly and how easily it was spread. The idea that people weren't wearing masks, and you can't really have someone wear a mask when you're examining their throat,
right,
or their nose, or in those areas. So tell us how has COVID affected your practice and your life as an ear, nose, and throat doctor, and really even as we go through a head and neck surgeon, how patients maybe weren't coming to the physician until hopefully very recently people are starting to come in and really getting evaluated for the general health issues.
Yeah, absolutely. We're in a unique position because they've shown that the highest kind of viral loads where a lot of the virus lives is in the back of the nose and in the mouth. So those are areas that we examine all the time. So we were sort of in a unique risk field, that would put us at risk. But I think we're very cautious as far as our protective equipment, as far as our everybody's gotten into a little bit of a pattern as far as our examination while we're have the patients take off masks at sort of strategic intervals. And same thing with the surgeries. Initially we were sort of trying to limit things that were inside the throat or kind of find alternatives where we're able to stand a little bit away from the patient using cameras or different techniques to sort of minimize our exposure while at the same time not compromising any sort of care. And now luckily with our rates that are somewhat improved, and with how good testing and the reliability and availability of testing, we're able to minimize unknowingly operating on COVID patients, because they've shown that if you are doing some of these head and neck surgeries on patients who are unknowingly COVID positive, that can have adverse outcomes for them. Now, as far as head and neck cancer goes, it's certainly, everyone's been a little bit nervous because it's been so long that people were hesitant to come to doctors. So the initial kind of wave, when people started coming back, the cancers we were seeing were quite a bit more advanced. And maybe that's just my sort of anecdotal, the way I experience it in my practice. I don't know if there's specific data on it, but it makes sense that a lot of people that were staying at home that was like, well, should I get this checked out? Well, you have to go expose yourself to an emergency room or a doctor's office where you could have COVID patients. It makes sense that you wouldn't go back until it really started impacting you. So yeah, I think it's totally reasonable. I totally understand the fear of going back to a doctor, but at the same time, definitely don't waver if you have some of these symptoms. If you're in pain, if you notice something that really looks suspicious, then you should come back, because I think we have a lot of good safeguards in the office and the hospital to prevent you from getting sick from other patients, and we're able to see you and treat you in a safe manner.
Absolutely, and we see this in all fields. And it was interesting, even in my field, we saw less patients with strokes, and some of the heart doctors were seeing less patients with heart attacks.
Right.
We didn't know where they were, and subsequently sad to say a lot of people were home and we really didn't want to come in. In our last minute, I just wanted to go over, you mentioned robotic surgery, and everybody's interested in cutting edge technology.
Right.
So tell us about robotic surgery with head and neck cancers and head and neck surgeries as a whole.
Yeah, so robotics is a relatively new field to head and neck. It was just FDA approved in the last 20 years. And it has really kind of revolutionized the way that we're able to, not that we're treating things that we didn't used to, but I think the manner in which we treat them, the morbidity in which it causes, and the sort of efficiency of the operating room has really improved with the introduction of robotics to head and neck. So we're able to treat some of these tumors, some of these cancers that we used to treat with a big, like you mentioned, a big disfiguring operation, where we have to cut the jaw and they need a temporary breathing tube in their neck and really prolonged hospital stay. We're able to do that through the mouth, using sort of the optics and the advantages that the surgical robot gives us. And as well, it's also used for things like sleep apnea surgery, and it could be used for benign lesions. Now, ultimately, it hasn't, I don't think it's significantly changed the way I treat patients with certain tumors. I think it's used as a tool that can really offer something and offer patients a minimally invasive approach to something that would have been much more invasive in the past.
Our half hour is over. I want to say thank you so much. I've learned a lot. And I always love learning a lot from our guests. And really the idea is prevention, as you mentioned, with regard to cigarette smoking, and just the idea that we have so many new treatments available really is so wonderful. And having a wonderful head and neck surgeon like yourself on Staten Island and in the New York City community really has helped us all, and really will help us all.
Oh, thank you so much.
Take care. It was a pleasure to have you here, and thank you again. Good night, everyone.